Hey everyone, thanks for joining the call. We're just going to give it a couple minutes there before we get started, just to give folks the opportunity to join. We'll probably get started, I'd say, around 12:02, so just hang tight. All right, we're going to go ahead and get started just with the essence of time for the presentation. Miigwech, merci beaucoup, and thank you so much for joining us for our Lunchtime Health Sciences webinar today. It's all in your head experiences from both sides of the stethoscope. My name is Bethany Thompson, and I'm the Health Sciences Programs and Partnerships Coordinator here at Awesome University. And today's webinar is being delivered by Patrick Balek. Before we get started, I will do a land acknowledgement and formally introduce our speaker. In the spirit of truth and reconciliation, Awesome University respectfully acknowledges that our pan-northern campus is on the homelands of First Nations and Métis people. The university buildings we occupy in Greater Sudbury and Thunder Bay are located on the territory of the Anishinaabe Nation, specifically Tikamitching and Wanapitei First Nations and Fort William First Nation. Beyond a land acknowledgement, we understand that reconciliation is a practice. We gratefully acknowledge the elders and knowledge keepers who share their gifts and teachings with us so that we may better understand and honor their wisdom and that of all the traditional keepers of this land. Awesome University will continue to practice reconciliation by listening, learning, and fostering a culture of mutual respect and trust. Just a general overview of today's agenda. We will have a 5-minute welcome and introduction, and then about a 45-minute webinar presentation from Patrick, and then a Q&A period at the end. This is a friendly reminder to please keep your microphone off for the duration of the webinar, unless you're asking a question during the Q&A period at the end of today's webinar. This will help to limit background noise for everybody. A reminder that this webinar is being recorded and will be posted on our Rehabilitation Sciences and Dietetic Practicum program web pages. All of our previous health sciences webinars are on the NAWSOM YouTube channel, and you can find the links to those recordings on our Rehabilitation Sciences and Dietetic Practicum program web pages in the resource sections. You can view these archive webinars at any time and receive a certificate for your professional development records when you complete an evaluation. If you do have any questions throughout the presentation, please feel free to put the questions in the chat, and these questions will be answered at the end of today's presentation during our Q&A period. Today's speaker is Patrick Balek. Patrick Balek is a registered nurse with a diverse background in critical care and education. He completed his bachelor's in nursing sciences, French baccalaureate at Laurentian University in 2017. He has since worked in various nursing roles, including 5 years on the inpatient cardiology unit at Health Sciences North in Sudbury, Ontario. And since 2022, he has served in the cardiac vascular thoracic intensive care unit. In addition to his clinical work, Patrick is a member of the clinical sciences faculty at Awesome University, where he has been tutoring and facilitating since 2022. He's also contributed to a standardized patient and collaborated collaborated with the Medical Council of Canada since 2019. As the founder and lead instructor of Vital Skills, he offers first aid, CPR, and basic life support training as an accredited instructor by the Heart and Stroke Foundation of Canada. Patrick began public speaking in 2024, sharing his passion for healthcare and education. He presented at the Northern Med Talks, the 55th annual scientific meeting of the Canadian Association of Neuroscience Nurses, and the 50th annual meeting of the International Society of Pediatric Neurosurgery. Then in December, he returned as a guest speaker for the Canadian Association for Neuroscience Nurses, Alberta South Chapter, for their Winter Neuro Nursing Education Day. Known for his infectious enthusiasm and kindness, Patrick is dedicated to learning from others and sharing his knowledge. His commitment to professional growth, advocacy for patient care, and teaching using presentations that have been described as eye-opening, incredible, and amazing, using phenomenal ways to present challenging and complex topics, making him a respected figure in the professional education communities. Patrick, thank you so much for joining us today and presenting on this very important topic. I'm going to pass it over to you to share your screen and your slides, okay?
Okay, thank you very much, Bethany. Okay. I just want to confirm that you can see my screen.
Slides look great there, Patrick.
Perfect, thank you.
You're welcome.
So in Canada, on average, 27 Canadians are diagnosed every day with a brain tumor. On October 9th, 2012, I was one of those 27 Canadians. You can see me here rocking my first ever IV. Let's talk a bit about brain tumors. They can be classified by the following characteristics. Origin, either primary or secondary. Primary originating from the brain and secondary coming from elsewhere, like a metastasis. It can be classified by grade, either 1 or 2 being low grade or 3 and 4 being high grade, or by the nature of the tumor itself, either benign or non-cancerous, or malignant. The brain is complex and it controls many essential aspects of normal daily living. As such, multiple signs and symptoms can be caused by brain tumors. Out of the 8 listed here, I had 2 of the most common side effects: visual disturbances and frequent headaches. There are no known causes for brain tumors, and they don't discriminate based on age, sex, ethnicity, or socioeconomic background. Due to the variety of ways brain tumor can present, signs and symptoms will often go unnoticed. It's often that a seizure will lead to the diagnosis, especially in the vulnerable populations like the pediatric and the elderly population, where symptoms have a tendency to be minimized. People with brain tumors may not look sick. I've heard more than once, but you have a brain tumor, but you look so good. Or maybe it's an invisible illness, right? Let's talk a bit about my story. My first symptoms started in June 2012. 2012, sorry. Right as I was about to graduate from high school. Mainly, symptoms were fatigue, loss of energy, headaches, and I went to see my family doctor, explained my symptoms, and he actually scheduled a CT scan. In July, I was starting to notice some visual issues with my left eye. I also had the CT in July, which turned out to be normal. In August, I went to see my optometrist. I explained my symptoms. He performed a very detailed examination and said that nothing was structurally wrong with my vision. He mentioned that the issue could be either vascular or neurological. I'll let you guess which one it was. Just to give you an idea of how my vision looked like, This is the vision with that is not impaired, and with my left eye specifically, you can see that there are words, but you can't see the letter uh, individually. My vision was kind of pixelated. In September, I started nursing school. This new beginning was nothing less than hectic. I lived in residence, and not only did I have a purple roommate for the first few weeks, but a social life that was quite active, which could keep me up quite late at night, whether I wanted to or not. On top of dealing with the immense workload that was involved with nursing school and the intense varsity swim team practices schedule. As September progressed, I noticed more symptoms. They were getting worse. I was having more headaches and more intense migraines, more fatigue, physical weakness, and dizziness with physical exertion. All the things could have been explained by stress, or from the workload of university life, or even just leaving home and becoming completely self reliant in a noisy residence. The only thing that could not be explained was the vision. You don't go blind from being stressed out. As such, in October, more and more red flags were showing up, and my parents and I decided to go to the hospital. My vision had deteriorated from August to October, and you can see here how the vision in the right eye was still perfect, but the left eye had significant loss in light sensitivity and increased blurriness. The changes in my vision were so gradual that it didn't sound an alarm until then. I was lucky enough to have a really, really good doctor in the emergency department. She listened to our concerns, performed a thorough neurological assessment, obtained a detailed history, and she knew something was going on. She was able to schedule an MRI for the next day. If you don't know, it's quite rare to be able to get an MRI within 24 hours, even in Grey's Anatomy. The next day, after my MRI, I had another doctor come by, and he told me, "We got the results from your MRI. You have a brain tumor. I know it's shitty news, but I'm on the phone with Ottawa and Sudbury to see who's going to take care of you. Do you mind traveling?" After the kindness and the attention from the first doctor, the contrast in behavior was staggering. I'm sure as healthcare workers, we've all had bad interactions with doctor and interactions that were even less than enjoyable. But when delivering sensitive and critical news like this, there are approaches that can be used. I'm thinking about the very simple, structured, but effective acronym SPIKES. That moment, receiving my diagnosis, and the way it was received shaped the way I approach and communicate with my patients and their families. It made me the kind of nurse I am today. Now, who says brain tumor says game time. Let's play Find the Tumor. This is the actual scan that diagnosed my brain tumor. I'll give you a few seconds to find roughly where it is. It's quite difficult, so let's add some gadolinium, some contrast to help out. Can you see it now? Without and with. The answer is right here on the pituitary. Kevin was the size of a marble. And who is Kevin, you might ask? This is Kevin, my brain tumor, one of the 120 different types of brain tumors. He's a craniopharyngioma. Craniopharyngiomas are known to be histologically benign, but locally aggressive. They usually involve the stalk of the pituitary gland. To help you remember where the pituitary gland is, I like to think of the pituitary as the scrotum of the brain. As such, let's not be indecent. Craniopharyngioma typically affect between 0.5 to 2 people per million per year. They make up 1.2 to 4% of all intracranial tumors. They have a bimodal distribution, commonly affecting people aged 5 to 14 and 50 to 74. I was 18 at the time of diagnosis. And they're classically very sticky brain tumors. They're adherent and can affect the hypothalamus, the pituitary, and the optic nerve, which explained why I was having some vision loss. That makes them difficult to remove and leads to high reoccurrence rate of about 50%. Radiotherapy and radiosurgery can mitigate the risks of reoccurrence. The good news, however, is that the survival rate for 5 years is 83 to 96%, and the 10-year survival rate is 65 to 100%. I am thrilled to be in that 10-year statistic. For those of you that don't know, what does the pituitary do? There's a really good comic from Awkward Yeti that explains it well. As you can see, the pituitary is very small, but mighty powerful. The pituitary is the king gland of the endocrine system. This system is intricate, and the tumor, like Kevin, can cause a wide range of signs and symptoms. About 40 to 87% of patients with craniopharyngiomas will present with at least one hormonal deficits. For me, being 6'1", I can tell you that my growth hormones were not affected, and as a man, oxytocin is typically not essential. If you have any doubts, also, I will confirm that I do not have a uterus or ovaries, so we can remove those from the equation. If we add Kevin, we can see that the effect was wide. All my hormones were decreased, some to near zero. However, my prolactin was actually increased. The prolactin is responsible, is important for delivery of newborns and in lactation. The typical range is 3 to 13 for men and 3 to 27 for premenopausal women. I was at 37. That is so ridiculously high, so much so that in my first week of diagnosis, an endocrinologist asked me if my nipples were lactating. And as an 18-year-old guy, that was quite a shock. Thankfully, they never lactated. Let's review quickly what hormonal deficits can happen. So the thyroid is responsible of fat, glucose, and protein metabolism. And as such, people that have hypothyroidism may feel quite tired because the body's not able to metabolize and absorb the proper nutrients or energy. Hypogonadism is when there's low production of sexual hormones. This is going to be specifically for post-puberty men, as the signs before puberty or for women of all ages would be different. You can see here again, there's quite a few different symptoms. They're not pleasant symptoms either. And again, 18-year-old guy, you don't want to have some of these symptoms. I didn't have all of them, but I definitely had some. Testosterone is also well known for causing hair growth and hair development. As such, a lack of testosterone may cause sparse body hair distribution or even a loss of hair that is already present. It puts a holy meaning to the song by Shania Twain, Man, I Feel Like a Woman. Adrenal insufficiency. Um, Cortisol is stimulated by the pituitary, and when you don't have the cortisol, it can blunt your fight or flight response and also cause a wide range of symptoms. Um, People that don't have cortisol don't get the or aren't as stimulated by the epinephrine and norepinephrine that's released by the adrenal gland itself. And this can cause adrenal crisis, leading to a hospitalization and high risk of complications. Arginine vasopressin deficiency, previously known as central diabetes insipidus, not to be mistaken with diabetes mellitus, or the one we know as sugar diabetes, diabetes type 1 and 2, causes failure in reabsorption of water by the kidneys, leading to increased urine output and increased intake. So the main symptoms are polydipsia, which is described as more than 40 to 50 mils per kilo per 24 hours of fluid intake. And since we're drinking a lot, we're also going to pee a lot. Um, and the polyuria can be categorized as anywhere from 5 to 20 liters per day of urine. That is a very, very big amount when we consider that usually for an adult it's less than 2 liters. Um, the urine will be clear and diluted, hence the word insipidus. Um, the urine will also not have much sodium, therefore causing a increase in the concentration in the blood of the blood itself and increase in sodium, that which again can be quite serious. So if we look at the at this tiny little tumor and look at all the possible side effects it can cause, would you consider this non-life threatening or non-aggressive? Because personally, I wouldn't. And this is the definition of benign. That's why in 2021, the World Health Organization classification of tumor of the central nervous system changed the term benign to non-malignant. Let's keep the benign for bingo out of brain tumors because brain tumors are nothing to gamble with. Now, we know the impacts of the tumor, but how do we treat the tumor? Considering that prior to my diagnosis, all the hormonal deficits could have been managed with medication, which would have effectively hidden the tumor and delayed treatments. This reinforces how it's important to have a clear clinical picture of the patient and not stick to treating symptoms only. In my case, treating the cause is the priority. After my diagnosis, I was sent to Ottawa Civic Hospital, and I quickly realized that the food from the hospital was not as appetizing as it looks, and it doesn't look appetizing to begin with. A diabetic muffin for an 18-year-old guy who is not diabetic really brings down your spirit. Thankfully, Tim Horton came to the rescue more than once. I was discharged from the hospital and told to wait for a call to schedule the surgery. I went home, kept up with my schoolwork remotely before the remote school was more popular. Then we headed to Ottawa for the pre-op the day before my surgery, and I was told that my surgeon was outside the country doing surgery, and it had to be pushed to the next week, which ended up falling on Halloween. Let's say that I was expecting to do more exciting things on Halloween in my first year of university. I got a trick instead of a treat. The first surgery lasted about 9 hours, and they used the endoscopic transnasal transphenoidal approach, meaning they would go up my nose to remove the tumor. This is less invasive and promotes quicker recovery. Recovery was interesting. I learned, I quickly became bored of staying in bed and trying to recover like a normal patient. And I was trying different things to keep myself entertained, like wrapping my IV around an ice bottle to see if it cooled down my IV fluids, which it didn't. And I also realized that the recovery wasn't going to be as easy as I thought. Just sitting in a chair for the first few days when it was enough to drain the little energy I had for the day. I discovered that the tube I had up my nose was actually a Foley catheter with a little balloon used to put pressure on the operative site, preventing cerebrospinal fluid leaks. The day after the surgery, November 1st, Movember started. And because I couldn't grow a mustache, because I didn't have much testosterone, I decided to reinforce the term mustache dressing. Humor, if you haven't noticed, had an important place in my brain tumor journey. I went back to school 2 weeks after being discharged from the hospital because I am a big nerd and I missed my social life and the possibility of finding some sense of normalcy in the chaos that the past months had had been was very motivating. There may have been some denial, maybe denial of the limits or refusing to accept the impacts and the restrictions that Kevin imposed on my day-to-day life. Or maybe was trying to protect my friends and my family from the reality of the struggles that we were going through. Going back to school also meant catching up on the midterms I had missed around the time the holidays were starting. But as December came by, I was having more trouble with my emotions, more frequent headaches, and excessive fatigue, and my vision was going down in both eyes. So, New Year comes around, new year, new me, right? But the red flags were up again. So, we called my neurosurgeons, and the next day I had an appointment for an MRI and an appointment at the ophthalmologist. And after my MRI, I was told I had a cyst that was growing and a possibility that the tumor or an infection may have reoccurred. So my second surgery happened January 4th. Um, I was going in for surgery within 24 hours of getting to the hospital. This surgery lasted 5.5 hours and they used the same transphenoidal approach. The recovery went really well. I was feeling much better much sooner than I did the first one. But immediately following the surgery, I was told I needed a third surgery because the tumor was just so aggressive. This time, they did a typical craniotomy when you think of people having brain surgery, where they cut open part of the skull and remove it. But I received an initial date, which was then delayed because my neurosurgeon had an emergency outside the country. So I went back to school, trying to catch up as much as possible, and waiting to receive a date for my third surgery. Once I received it, back to Ottawa we went. This surgery lasted about 7.5 hours, and it was an orbitozygomatic craniotomy, which is more invasive, but however, I wouldn't have to have packing up my nose or a Foley catheter. But again, the recovery was more difficult. The main goal was to save the vision in my right eye, as the tumor had permanently affected my left eye. But I channeled my inner Rocky Balboa and kept fighting on. My plans to go back to school were stopped very quickly as the tumor had grown between the 24 days between the second and the third surgery. I was going to need radiation for 6 weeks. We couldn't afford to wait because the vision in my right eye may become even more compromised. So I left school and started radiation soon after. I was on two different machines. The first one looked like a CT scan, the typical donut where you go in and out. It was more invasive, but then I had the CyberKnife. Last time I checked, there were about three or four in Canada and one being in Ottawa. This machine was precise to the millimeters. The first 5 treatments were on the other machine, and the next 25 would be on this one. The treatments on the first machine lasted about 5 minutes each, and unfortunately, because this one was quite a bit more precise, it also lasted about 45 minutes, which meant having to stay on the table without moving for 45 minutes. But it also meant I had the ability to have awesome pictures. So this is actually a picture of my skull after the third surgery. So soon after that, I still had the staples on, and this is what they used to plan the radiation. You can see here the different beams they could have used, with the red ones being the one they didn't want to use, and the dark blue ones being the one they could have used but didn't use. You can also see the different size of beams that were shot at my tumor. Um, Going back to the first one, when I first saw this image, I thought, I have really nice teeth. Radiation caused the tumor's surrounding tissue to become swollen, causing further vision loss. I was practically unable to perceive light changes in the left eye, and the vision in my right eye was kind of half blurred, making it difficult to read as I couldn't see the whole word. I learned that resting whenever and however was a necessity, and to listen to that voice in my head saying that I had to rest. I like to compare a brain with a brain tumor as an old cell phone. It takes a long time to charge, and the battery also drains very, very quickly. The last day comes around. I get to ring my radiation bell with my team. Those workers had been with me at my side through the past 25 days, and I was looking forward to ring that bell. Well, triangle. I kind of wish we would have had a gong like we have here in Sudbury, but I rang the hell out of that triangle. The last 7 weeks had been extremely challenging on my parents and I. So I recovered over the next few months and then went back to school in September. I had been able to finish my first semester classes, but had to abandon the second semester classes. Since then, I've reached some pretty major milestones. I've graduated, started my career, bought a house, started my own first aid CPR business, adopted my cat, Betadine, and started working in the ICU. But what's next? The future can be unknown, but I can tell you I got accepted to present at the World Federation of Neuroscience Nurses. So in July, I will be heading to Australia to present my story. But you don't know what the future holds. I want to make it clear that it doesn't mean that you have a brain tumor that you can't reach those goals. But people with brain tumors may face extra hurdles and delays that won't apply to people or may not apply as much to people without brain tumors. However, just like the same tumor can, even in the same location, won't affect two people the same. The sad reality is that sometimes the hurdles might be too high to overcome with the society that's not able or ready to accommodate special and unique circumstances. Let's talk about the multidisciplinary approach. So, with all the symptoms that could have happened to my tumor, and again, this is limited to some symptoms, we can use definitely a multidisciplinary approach. With the increased risk for hypotension, cardiac arrhythmias, and the blunted fight or flight, the PT and OT will be important for falls prevention, environmental adaptation, and adapted exercise programs. With the nausea, vomiting, diarrhea, or constipation, and increased risk of hypo or hyperglycemia, the dietitians will be important in helping modify the diet, make sure that there's proper hydration support, manage the side effects from medication or the illness itself. The body image changes that come with those side effects or just with a diagnosis, including the sexual dysfunctions and dissatisfaction, can be quite significant, and there's still a taboo surrounding it. So social workers play a key role in providing that psychosocial support, counseling the partner or the caregivers, and connecting resources with the patient. The polydipsia and polyuria increases the risk of electrolyte abnormalities. There, the dietitian can still step in. The polydipsia and polyuria increases the risk for falls because I didn't just pee a few times a day. I would pee every 15 to 20 minutes. And it wasn't just a little bit, it was a lot. So think of your elderly population that may fall while going to the bathroom, or those are the things that are important. The environmental assessment, making sure there's enough lights, or PTOT are important for that. Increased risk for fractures, again, PTOT, essential in managing that and with our dietitian to make sure that to prevent bone loss. There's the weight loss and weight gain. Pretty much everyone's important in that. Um, Whether psychologically or physically, it's going to have an impact, and it's not always the pleasant impact. People with brain tumors will often be on steroids to decrease the inflammation in the brain. These cause significant weight gain and mood disturbances too. Again, muscle loss, muscle weakness. We want our OTPT involved in that. The nutritional deficiencies, dietitian can help with that. Speech and swallowing dysfunctions, we have our SLPs that can have a major role in that, in swallowing assessments, modified diet, or speech therapy, bringing alternative communication methods, or choking prevention, psychological support, and counseling too. And we have the cognitive, behavioral, memory, attention, executive processing dysfunctions, the low energy levels, the sensory motor and gait deficits. Everyone can be involved there. It's really not a nurses and doctors approach only, especially when the patient is discharged from the hospital. Now, I like to talk about the lessons I learned as a patient and as a healthcare provider, because I've been both and I've seen the reality of being on both sides. So let's look at the top priorities. I have aimed it towards nurses, but I know it can definitely apply to um, everyone that's involved in patient care. So we'll approach and prioritize assessments based on a head to toe fashion. We'll administer treatments, respond to emergency or unexpected events that may arise. We'll have to document, and God knows we have a lot of documentation to do about our interventions or any kind of assessments we do. We have to check off a to-do list, whether it's form interventions or scheduled tasks, meetings, and we need to repeat this for multiple patients. On the patient's point of view, their priorities may be finances, from parking to hotel, loss of income, traveling, insurance, medication, home care, and so on. The costs adds up. Managing the mountain of information we receive from all healthcare providers about the illness, the medications, the risks or benefits of doing or not doing a treatment or therapies, and adapting or accepting the changes in the plan of care. This on top of dealing with the emotional, mental, and physical toll of the illness. Not knowing what the future holds. Something as simple as leaving the hospital or not knowing when you can shower or eat, that loss of control is causes a huge amount of powerlessness. Juggling friends and family. When and how much information will you give, if at all? Dealing with the reactions and the emotions. Sometimes they're worse than the patients themselves, and the crossing of the boundaries. How the illness is going to affect you long term, and the residual effects are going to affect work and school. Both of these are strongly linked to both social and financial stability. Not to mention the possible stigmas attached to returning to work or school, requiring accommodation, or the stigma of the illness itself, and being heard in healthcare. Taken seriously or even believed when you're ill or in a hospital bed with those ugly green gowns. It's very difficult to be heard in the hospital. This might also affect the willingness to return or seek healthcare in the future, and affect the perception of what healthcare is and what it has to offer to them. If we look side by side, we can see that most of our priorities don't align and some actively go against each other. But I found one thing out of multiple that can assist your patients and their loved ones in their care, and it's listening. Even better if you can sit down. This is especially important with our pediatric population and vulnerable population that are in bed and can't stand up or sit. Sitting down helps decrease the power dynamics that strongly favor the healthcare worker. It shows that you take your patient's concerns seriously and that you will make time for them. It also emphasizes time of quality over quantity of time, because we don't have lots of time in the hospital. Amongst other things, you can also do these: being honest with your patient and finding a way to be empathetic without sounding robotic. If you don't mean the emotions behind the words, the patient will know. It doesn't mean that they're ill, that they can't recognize false empathy. Like, oh, I'm so sorry to hear about your very significant diagnosis. Do you have regular bowel movements? And knowing your limits. I've had one nurse when I was in the hospital, and I asked her a question and she said, I don't know, but let's find out. She took out her phone, looked up the answer. There. Not only was she honest about not knowing her knowledge, or about the limits of her knowledge, but she actively found an answer. Again, simple but very efficient. If you don't know what to say in an emotional situation, something like, I really wish I knew what to say to help relieve some of the pain or the distress or the worries you have. Or, what you're feeling is normal. Or even, I believe you. By doing so, you communicate the limits of your ability to support the patient, but you're also validating that what they're experiencing, without becoming insensitive or faking your way with false reassurance. Lastly, if you feel like you're becoming less yourself as a nurse, or a healthcare worker, it may be a sign to take a step back. Invest in self-care, whether it might be a vacation, therapy, decreasing your hours, or exploring other departments or work opportunities. With another employer, maybe. You need to take care of yourself so you can take care of others appropriately. Very simple, very difficult to do. You should be your priority. And I know it's easier said than done, but don't wait until you have a serious issue to realize it. My neurosurgeons had the biggest direct impact on my health, but they also taught me the impact of pristine bedside manners and how taking your time reflects a special investment in your patient. But you don't have to be a neurosurgeon to have a direct impact on someone. My radiation technicians, they were my angels. They were caring, took time to see how I was doing throughout my treatments. I saw them every day for nearly 2 months. That's more than I see some family members in a year. These check ins went a long way to make me feel heard and supported. Jazzy, she was our waitress at Cora. She made me laugh on a particularly gloomy day and took the time to connect with my parents and I. She didn't know what we were going through, but she made a big difference that day and she recognized us when we came back later. She developed with us a better professional relationship than I've seen some providers with patients they've had for years. Dealing with long-term side effects of the tumor, the surgeries, the radiation, along with adapting to the new normal is often challenging at the beginning. Since the end of my treatments, I dove headfirst into the brain tumor community, connecting with fellow brain tumor warriors, patients, and caregivers from across the world and leaning on them. Sharing our experiences brings a unique but relatable and much, much needed way of supporting each other and creating bonds like no other. I've presented mostly the good aspect of my journey, and I've used humor as the main coping mechanism. But believe me, it wasn't always funny, bright, and positive. There were some moments that only my parents and I saw, or that we see as healthcare providers in the hospital. But there's battles that we fought outside the hospital too. And there's a quote that represents these kind of moments quite well. Happiness can be found even in the darkest of times if one only remembers to turn on the light. You've probably noticed me saying we are us. We went to the hospital. She took our concerns seriously. We went through. That's because I was blessed enough to have amazing parents. My parents didn't only remember to turn on the light, they were my light. My experiences reinforced how essential it is for the healthcare team to include the patient's family, whether it's a chosen or given family, in the circle of care. I've experienced firsthand the importance of having and leaning on a support network. I learned how humor can make dark moments a little easier. And without humor or social support, especially without my parents, my outcome would have been very difficult. I want to leave you with these few things. We can't control everything that happens in life, and controlling our reaction to this other absence of control can be extremely challenging. By acknowledging this and understanding that we don't know what other invisible battles others are going through or have gone through, and by having a kinder approach and increased awareness to others' needs, we enable ourselves to be able to provide support and motivation that they may need at that time to fight their versions of Kevin. After all, it doesn't mean that it's all in your head, that it's not real. It may just be your brain's way of revealing a previously unseen, stronger, and more sensitive side of you. Thank you. If anyone has any questions.